Greetings from Chennai Rheumatology and Immunology Center. I am Dr. Chandrasekhara S., rheumatologist and medical director of Chennai Rheumatology and Immunology Center. I will be speaking to you about the World Ankylosing Spondylitis Day, the May 7th, where we dedicate the entire day in educating the patients as well as the general public about ankylosing spondylitis. So what is this ankylosing spondylitis? Ankylosing spondylitis is a form of arthritis which is seen predominantly in men. It is one of the systemic rheumatic diseases. It's also often classified as seronegative spondyloarthropathies. What is this ankylosing spondylitis? How does it differ from other arthritises? It primarily affects the spine and sacroiliac joint. Stiffness and pain are the predominant symptoms. It is often been attributed and associated with HLA-B27. So what does it mean is, in a patient who has ankylosing spondylitis, 9 out of 10 will have HLA-B27 positive, whereas if you have HLA-B27, you are likely to have this disease, but at a rate of, suppose out of 10 people who have HLA-B27 positive, one of them may develop ankylosing spondylitis. So it's not that everyone who carry HLA-B27 will develop ankylosing spondylitis. It's only 1 out of 10 who have HLA-B27 will develop ankylosing spondylitis. It is grouped under the classification among arthritis as seronegative arthritis. This has happened because earlier days we used to have two different types of arthritis in our understanding. We used to call rheumatoid factor positive group as rheumatoid arthritis and other group which were negative for rheumatoid arthritis, which we used to call it as seronegative rheumatoid arthritis. This disease predominantly affects men. So if you look into the incidence, majority of them who are affected by the ankylosing spondylitis are men, and women are less commonly affected. Usually if you see around 7-8 men being affected by ankylosing spondylitis, maybe 2 or 3 of women may be affected by ankylosing spondylitis. So it's most commonly found in men. What is our concern when it comes to the ankylosing spondylitis? In ankylosing spondylitis, other than the pain, what we are worried about is the normally looking spine, where the spines are separated by a vertebral disc. They gradually, because of inflammation, goes on fusing. So the disc space comes down, the ligaments which bridge these bones become fused, and as a result of which the spine becomes into a rigid structure, something what in X-ray we call it as a bamboo spine. So this is what happens is, as a result of continued disease process, the spine which is highly mobile, an individual who is otherwise erect and have a flexibility of moving forward bending, backward bending, side to side bending, gradually bends forward and the spine becomes stiff, and as a result of which he becomes, his mobility of the spine becomes restricted and slowly bends forward, resulting in what we call as a restricted spine movements. Usually it doesn't happen overnight. It takes 10 to 15 years of disease for one to develop this condition. So why does this ankylosing spondylitis occur at all? So as I said, it occurs in the presence of a HLA-B27 genes. Just to remind you, it can also happen in the absence of the gene, but it is less common. So when the genes are present, as a result of varieties of reason unknown, including some of the triggers like infection, stress, smoking, and variety of these environmental triggers, including lifestyle, may trigger and alter the immune response to develop either increased IL-1 production or increased TNF productions in the joints and the ligaments that results in the persisting inflammation, which is why and which is the reason how an ankylosing spondylitis develops. This research is going on, why it develops in some individuals, what are the other reasons, how to prevent and how to alter it. But I think we have come to some amount of reasonable information that TNF, IL-1 and few of the cytokines alterations or aberrations is one of the responsible factor for the development of the disease. So what are the symptoms? The main symptoms are the stiffness, pain, limitation of the movements and severe fatigue. So the usual Usually it occurs in younger patients between 15 to 30 years. Disease progresses. As the disease progresses, as I showed, spine fuses. That's why we use the term ankylosis. There is a normal loss of spine curve, there is a reduction in motion, and there is fixed bend forward position, which can result in a severe limitation of the movement. In addition to the spine and the back pain, patient may also develop the joints, pains in the joints like shoulder, hip joint, elbow, and other small joints of the hands. But its small joints of the hands are unusual. Usually it is a larger joints like hip, pelvis, and the shoulder. There are many reasons which can cause back pain. The back pain is one of the commonest problems for all of us. When should I, as a patient or as an individual, should worry about the back pain to be shown to a rheumatologist to be considered it as a possibility of a ankylosing spondylitis? We use a term called inflammatory back pain in rheumatology. What we meant by inflammatory back pain is when the back pain is present and it develops over a period of time. It takes some 2 to 3 months, starts slowly, gradually it worsens, and the pain which is worst at night, and the pain which is usually this kind of back pain occurs in the age below 45, and it improves with exercise, and it doesn't improve with rest, or on the contrast sometimes it worsens with the rest. As I said, the pains are worse at night when you sleep, when you are relaxed. And as soon as you get up in the morning, you find it is very stiff and you are not able to move immediately. And the stiffness may last for more than 1 to 2 hours. And when you start moving gradually as the day progresses, the pain may come down. Or if you do little exercise, it improves. This is a very typical feature, what we call as inflammatory back pain, which is what we see in a majority of the ankylosing spondylitis. We do have seen quite often these back pains may is confused to slip disc. In slip disc, usually the pain is acute onset if you have a fall, or it could be a subacute onset where it may develop in a week to 2 weeks time. Usually it improves when you are at rest if you put a splint, and usually at night when you are asleep it is better, and as you start moving it becomes worse. If you do the exercise, it all the more it becomes worse. So this is how typically a slip disc differs from a inflammatory back pain. So in addition to that, one can have an extraarticular features like iridocyclitis, involvement of the eye. One can have a skin in the form of psoriasis. You can have diarrhea as a form of inflammatory bowel disease. Finger may be swollen as dactylitis. Where the muscle get attached to the bones, what we call as ligaments or enthesis, may get inflamed, what called enthesitis. There could be joint and nail involvement. Sometimes it could be accompanied with psoriasis. Why are we concerned about the disease? What does ankylosing spondylitis does to anybody other than the pain? See, the pain itself is a problematic scenarios. When you have a back pain, when you are unable to get up in the morning, when you are not able to do day-to-day work the way you would like to do, so you defer to attend a lot of social activities. You wake up with a back pain. You feel like, why should I do any job today? So you literally get impaired in your professional efficiency, your anxiety increases. As a consequence, you may get depression, and there is inability to perform routine day-to-day activity on your own because of the inflammatory back pain and the discomforts you have. So that's how the ankylosing spondylitis can seriously affect the quality of life. How do we diagnose ankylosing spondylitis? One is clinical examination. As we said, your pain, your complaint, the way the symptoms are, and when we examine the restriction of the back, swelling in the joints, and in blood test where your CRP, ESR are increased, and we also sometimes check for liver functions and other, just to exclude other possibility. A genetic testing, HLA-B27, the gene assessment should help you. It is not necessary, as I said, it should be positive. It is positive in 1 out of 9 or 8 patients, and positivity doesn't always tell that whatever the back pain you have is because of ankylosing spondylitis. X-ray will help in identifying sacroiliitis, which is the responsible factor for, which is one of the identifiable factor for ankylosing spondylitis. MRI will be useful in the early phase of the disease. So why usually we get the diagnosis delayed? Why very often ankylosing spondylitis is diagnosed at least after 3 to 7 years of the onset of the first initial symptoms. Usually the delay in diagnosis is because patient sees an expert rheumatologist late in the course of the disease. X-ray may not be showing sacroiliitis in early disease, or sacroiliitis may be very subtle. It may not be very typically what you can see. Especially in women, since we don't suspect them to suffer from ankylosing spondylitis, we miss, and we don't have a lab specific test. As I said, HLA-B27 may serve as a genetic marker. Even if it is positive, it is not necessary you have ankylosing spondylitis. Even in its absence, it is not necessary that you can exclude ankylosing spondylitis. That's how it is not very specific and very sensitive. So there is no specific marker which can help you to make a diagnosis of ankylosing spondylitis. It is your expertise, your perception that makes one to diagnose ankylosing spondylitis. That's one of the reasons why there is delay in making a diagnosis of ankylosing spondylitis. So having said that, after diagnosing, what are the available treatment? See, we use a term called there is no cure for ankylosing spondylitis. The reason is the ankylosing spondylitis is driven partially by genetics. As a result, gene being persisting, we don't have a permanent solution. When we meant a permanent solution in medicine, it means that it is not that you are going to prevent the problems. It's not that your pain and stiffness don't go. With the treatment, the disease comes under absolute control. When the disease comes under control, the disease progression reduces. The disease moving to an stiff back, hunchback will be prevented or reduced. And at the same time, if things work out, your disease may completely quieten down, may not come back for rest of your life. For you, it may be called as cure, but for medical fraternity, we don't use a term cure, because when we mean a word cure, we mean the disease don't come back in majority of the person. Here, what it may happen is, in quite a good number of patients, around 40 to 70% of the patient, disease may relapse. So as a result of which, we may not consider the disease to have a cure, but definitely it has a treatment. The treatment really improves the quality of life. So some believe that using simple calcium, vitamin D and bisphosphonate may help. They may not really help the conditions, but they may support the conditions of this. What are the modalities of treatment that are available? One is we use non-steroidal anti-inflammatory drugs. They are naproxen, celecoxib, indomethacin. One of these drugs can help in improvising the pain and stiffness. We use drug like disease-modifying anti-rheumatic drug like methotrexate and sulfasalazine, which can help in improvising the controlling the inflammation. There are newer generation drugs called biologics like anti-TNF therapy, secukinumab, anti-IL-17 therapies. So biologic drugs like infliximab, etanercept, adalimumab, golimumab are useful. Of late, even a new generation drug called synthetic target DMR, tofacitinib, has been approved to be used in ankylosing spondylitis. So we have a lot of medications that can help the patient to come out of his stiffness and reducing the overall progression of the disease. In addition, if things goes bad, if the spine gets fused or the joints gets damaged, we have a surgical methods. But if you diagnose early, take an appropriate treatment, surgery can be prevented. A good physiotherapy helps a lot. You maintaining postures, keeping the erect spine, good relaxation, keeps the muscle tone, everything intact. So that's why a good physiotherapy, regular exercise, maintaining posture and posture training is going to make a big difference in the patient suffering from ankylosing spondylitis. Yogasanas and yoga therapies, at least doing 20-30, especially back-based yogasanas like Surya Namaskara, etc., can help you a long way in improvising and keeping the mobility of the spine intact. So one of the other safety issue is if then there is a fused or immobile or inflexible spine, one need to be careful because a small fall can cause a fracture, and one need to avoid fall, etc., and take precaution when you are getting in car, getting out of car. Smoking and alcohol can worsen the situations. It's best to stay away from that, and using appropriate mattresses, trying to keep the back as flat as possible, as straight as possible, reduces the development of hunch. What is about the weight? It's better to maintain weight, keep the maintain according to BMI. There is no specific food restriction which are recommended with reference to ankylosing spondylitis. One can eat every food, but keep a watch on your food so that you don't gain weight. And a good exercises and maintaining a good posture and a body weight is going to make a huge difference in keeping a good quality of life. So now the question that comes is, having described so much, are you afraid that is it difficult to live with an ankylosing spondylitis? The answer to that question is, it's not that. One can live with ankylosing spondylitis. You may develop physical limitation, but that physical limitation can be kept up. But if when you are having a trouble, you always ask for help for the family, friends, and counselors who play a very important role. We encourage your social activity and participation that keeps you engaged. Engagement at professional office places, participate in ankylosing spondylitis support group, speak to your rheumatologist, doctor, or a physiotherapist how best you can work with ankylosing spondylitis. So the answer is, you can handle ankylosing spondylitis, live with it with a good quality of life. It's all the more achievable, especially when you go for an early diagnosis and right treatment. So early diagnosis is the key. So that's why identifying and recognizing yourself that whether I have an inflammatory back pain or not, and consulting with a rheumatologist or a specialist in the field of ankylosing spondylitis will help you for an early diagnosis and appropriate treatment and maintaining a good posture and a good quality of life. Things like meditation, good mindfulness will help you in improvising your overall outlook and quality of life. Another major question, because as I said, it attacks youngsters, young male. And often the question that remains in their mind, can I get married? Do I have a normal married life? And if it's a girl, her problem is, can I get married? And can I become pregnant? Is pregnancy going to be safe? So coming to men and women, yes, both of them can get married. And really the ankylosing spondylitis do not affect the reproductive system directly. Pains and aches may trouble you now and then, but if you properly manage your treatment, properly take care of ankylosing spondylitis, that's not going to be a hurdle. Do I pass it on to the next generation? Answer to that question is no. There is a good prevalence of this HLA-B27 in the community. HLA-B27 is one of the protective gene. It has its own positive role with reference to health and diseases. And when if it comes to the next generation, he has a 1 in 10 chance of developing an ankylosing spondylitis. I mean, that's not a big defect, and it's not something non-treatable disease. So you need not worry about your next generations. HLA-B20, even without HLA-B27 positive, one can develop ankylosing spondylitis. So you are not committing any serious errors or serious blunders. So that being the case, so you can get married, you can think of having your own progeny or generation. Regarding pregnancy, though around a very small percentage of women are troubled by ankylosing spondylitis, usually female with angst conceives without any issues, and the pregnancies are normally uncomplicated. Babies who are delivered are also normal. Only one problem sometimes they may encounter, if the ankylosing spondylitis has affected them in early, and if sacroiliac joints are fused, a normal delivery may not be possible. One may have to plan out for a cesarean section, and that should not be a major issue, because no longer cesarean section is considered as a serious surgical procedure that is required. So the major other questions that always daunts everyone is, should I call this as a hereditary disease or a genetic susceptibility disease? This is not to be labeled as hereditary disease. Hereditary disease, when we mean by definition, is if it is a disease carried forward by a defective gene. HLA-B27 is not a defective gene. HLA-B27 is a MHC class molecule. It has its own function, positive functions, but these are what are called as genetically associated disease or genetically susceptible disease. If you have this HLA-B27, chance of you developing this disease increases. So it means these are not categorized under genetic disease, they are hereditary disease. We categorize them as genetic susceptible disease. So that is what we call as, you see a cluster of this disease and you have a tendency to develop that disease much higher than an individual who do not have this particular gene. When it comes to hereditary disease, without that gene, the other person will not develop the same disease. So that's why I think this should be clear both to the policymakers as well as to the patients, that these are not called to be as hereditary disease, they are to be called as genetic susceptible disease. So one of the things that we are worried with Ankylosing are flares. There could be recurrent attack if you don't manage properly, especially when you get infection, smoke, get stressed, or irregular on treatment, don't do regular exercises. You may have repeated flares, and that can be managed with intermittent increase in medications or introduction of medicine. One may reach to a stage of remission where the disease is completely quiet. At that time, one may withdraw most of the medications and keep a watch, and regular exercise should take care. One should take care with good exercise and hygiene practice. One can avoid flares and relapses, and so appropriate and a proper care can avoid flares and keep you in a good remission status. So don'ts are: when you have a fused spine, try to avoid heavy lifting, but you can manage it, but should be up after getting an appropriate posture. Please try to maintain a proper position. Keep your back straight when you are sleeping or sitting, and frequent bending forward, backward bending should help you in avoiding the posture misalignment. So with these simple precautions, with ankylosing spondylitis, one can live a normal life. Ankylosing is not a disease of concern, but a disease to be identified and managed appropriately. One can lead a normal life. Thank you very much for patience hearing.